want to give folks another minute or two to log in. I know the internet's kind of wonky today, so bear with us. A few people are having problems signing in here. So we're just going to start in another minute. Thank you. Okay, I think that was another 60 seconds. So I'd like to start the Shea lecture today by welcoming all of you. I'm Carol Hall, Executive Director of the Charter Oak State College Foundation. And on behalf of the college, the leadership, our board of directors, West Hartford Chamber of Commerce, and the Minority Business Network, we want to welcome you all to our second of 3 Shea lectures, Shea 2. The Shea lecture series is provided by the generous contribution of Charter Oak's first president, Dr. Bernard D. Shea, to further the mission of engaging students and the community in lifelong learning. The Charter Oak State the foundation leadership began this year planning to host one biannual Shea lecture on the topic of economic disparity and solutions. But as the year began to unravel, we knew we needed to do our part to start a productive conversation on economic and racial disparities with a focus on solutions. The Shea lecture in September began with an overview of the origins of economic and racial disparity by Dr. Fred McKinney. We learned so much on that call from our distinguished panels, and I would encourage anyone who hasn't seen Shea 1 to take the time to watch this lecture series. We had engaging conversation, and it really brought us to the decision that we needed to continue the conversation. So here we are with Shea 2. Today we anticipate an exciting, engaging discussion also, and we are glad to have you here with us for this important live discussion on disparity. If you're familiar with Zoom, you will notice the chat room for discussion, and we also have a question and answer chat that will be monitored for questions to our panelists. Please be sure to use the question and answer for questions. Also, please note that today's recording will be recorded and available for viewing later on YouTube and Facebook. After a few words from Chris Conway, Executive Director of the West Hartford Chamber, we will introduce our moderator, Tracy Allen. Then Tracy will introduce our panelists and host the discussion. I want to thank you all for taking your time and your interest in attending today. I also want to thank our talented and knowledgeable panelists. Thank you. Chris?
Thank you, Carol, and thank you to our committee, Foundation Board members Glenn Davis, Dave Calaby, Ann Elwell, and Tracy Allen, plus the West Hartford Chambers staff, Kate Cobes, who is producing our Zoom today, and Jesse Bouclier, who will be monitoring the chat. Also, thank you to our panelists and to you and our community. Your participation as the audience is imperative to moving the discussion in our communities towards solutions. I would also like to thank our partners at Charter Oak State College Foundation for their collaboration in continuing this solution-based conversation started in the first lecture in the series. Inequities in access to healthcare, educational resources, and food insecurities. The West Hartford Chamber of Commerce, in conjunction with our Minority Business Network, is committed to being a partner in bringing about change. I would also like to recognize Christopher Clark, who is the chairman of our Minority Business Network. Chris cannot be with us today, but he did ask me to extend his thanks and best regards. Now it is my pleasure to introduce today's moderator, Tracy V. Allen. Tracy is an impact strategist, speaker, author, and educator with a passion for helping organizations thrive structurally and financially. Tracy is a former English language educator and now founder of an engine behind TVA Consulting. She has over 20 years of experience in social enterprise sector, helping clients maximize their social impact. When Tracy isn't strategizing for clients, she's doing volunteer work for SCORT, the Greater Hartford chapter, and co-chair of Education, Inclusion and Diversity Coordinator, a fundraising team member, as well as representative of the Small Nonprofit Community Partner Committee. She also sits on the board of Charter Oak State College Foundation and Black Business Alliance. Tracy Allen.
Hi, everyone. Welcome to today's Shea lecture, the continuation of economic disparities and solutions, healthcare, and education inequities. This is a solution-based discussion, not one that just talks about the problem or the political aspects of the issue. It's about how we as a community can come together to solve the issues that we're having when it comes to economic disparities, especially today in healthcare and education. So without further ado, let's get started with our first guest. Our first guest is Dr. Brooke Palkey. She is the chair of Health, Science, and Technology Department of the Charter Oak State College and program director of Healthcare Administration and Health Informatics graduate program. Dr. Palkey has her PhD in education and is a registered health information administrator and fellow of the American Health Information Management Association. She has a teaching focus on classification, vocabularies, clinical data standards, as well as assessing health quality and corporate compliance. Dr. Palkey is an approved trainer of the International Classification of Diseases, 10th Revision, Procedures Code Systems, and has been involved in several healthcare grant-funded research programs. Prior to her higher education career, Dr. Palkey worked in leadership roles both within the hospital setting as well as for the state of Minnesota. Dr. Palkey has been working remote for many years and is with us today from Minnesota. She is also a native Alaskan and brings a view of societal disparities that is intriguing. Dr. Palkey, please join with us and give us some insight into education in the health, and joins us with her insight into education in the healthcare and the work to expand the net of care for the underserved in our community. Thank Dr. Palkey, over to you.
Thank you so much. I'm very happy to be here today. As many in the Native community, I am a first-generation college graduate. So it's extremely important to talk about, for me, having my background in healthcare and education and having those two merge, and knowing some of the disparities from the Native community, but really having a focus, a broader focus on social determinants of health. So I'm going to just introduce the topic of social determinants of health, and as Tracy mentioned, the importance of broadening that safety net between what we deem as traditional healthcare to filling the gap between conventional healthcare and public health. It's extremely needed, particularly now that we've had the pandemic. And as we know, the current public health crisis has really magnified the health inequity regarding access to achieving good health care. And this leads to unfair and unavoidable differences in health outcomes. I'm going to stress health outcomes because I'm going to loop back to that. But the differences in access and availability to resources are really driven by structural inequities that have a direct correlation to health inequities. And these arise from what are conditions known as social determinants of health. And when I talk about structural inequities, I really mean conventional healthcare. When we think about healthcare, we really just focus on that one point of service of care, or clinical care. And I like to think about the visual of an iceberg. So just the very tip of an iceberg, if it's floating in the ocean, you just see the very tip of it. And that's really that clinical care component that people see when you walk into clinical care. And then you have the massive body of an iceberg underneath the ocean that is not seen. And that's really the other components of the social determinants of health. So the social isolation, the employment, the food, the housing, all of the components that make up a holistic person that aren't being incorporated into that one touch point of healthcare. So the healthcare industry, as we know it, is the conventional version, is really in the early stages of truly understanding how to adequately capture, assess, and utilize social determinants of health. When we think of social determinants, it includes data points, as I mentioned, such as food security, level of educational attainment, income, access to care, reliable transportation, safe housing, etc. And it really encompasses a person's social network. So really thinking about socioeconomic status and thinking of income and education, these have really been the predictors for health outcomes that are being excluded from traditional conventional health. But we really need to bridge the social determinants of health to what we're considering health outcomes. And this is where we're seeing that conventional healthcare disconnect. And in proposal, I think that we could learn a lot from our federally qualified health centers to help shed light on how to broaden the health system to cast that wider safety net and have this true collaboration with public health to help reduce the inequities of care. If you think about determinants of health, so all health, think of if you can visualize a pie chart, and if you can think about when I talked about conventional clinical care, it is a little tiny slice of that pie chart. What makes up the majority of that pie chart is the social and economic factors that I spoke about. And the other component is actually social behavior. So what we learn, so that incorporates education. So the majority of our determinants of health are other components other than clinical care, and yet that is missing from conventional healthcare. So when we think about federally qualified health centers, it's a community-based health system of providers that receives funds from HRSA, and it provides all healthcare services in underserved areas. So it includes medical, it includes dental, it includes behavioral health, it includes all of the enabling services, which include transportation, making sure someone has housing. And the interesting component of federally qualified health centers is 51% of boards in federally qualified health centers have to be made up of the representative population. So so the people who provide input on the care that should be provided and the types of services that provided directly represent the population that's being served. And they treat patients regardless of ability to pay. And it reminds me of Native Health Services, where it's the same kind of setup, where you're getting all of the services provided. So it's more of like a healthcare home model versus just having separate individualized silos of this is primary care. Then you go to your dentist, and there's no communication and there's no closing the loop of that full view of a person's well-being and well-health. The problem with federally qualified health centers and with Indian Health Services and in some components, the VA would be another example of this type of non-conventional setup, is their locale. So geographic location. So my BIA is registered with the 13th region in Akiak, Alaska, and I live in the lower 48. Well, there's no way I'm going to be able to go to my health center. And you're only represented if you go to your health center. So there's an issue. Luckily, I'm employed by an organization who provides healthcare that is the only, so I get conventional health care, but that's the only way that I am able to get that, even as enrolled with a BIA. But the other component that people can educate themselves on is utilizing the organization of AHRQ. It is the Agency for Healthcare Research and Quality. And if you have not done so, they released a report on the progress and opportunities for improving healthcare quality and reducing healthcare disparities. And the focus is on areas of strength and weaknesses, disparities, access for care, quality of care, and it's measured by group of priority areas. So safety, health, effective coordination, and affordable. But the interesting thing to me is that the latest report that was released was in 2008 and identified that disparities related to income and race persist, and that racial and ethnic disparities vary by group. So we have African American, American Indian, Native Alaskan, Native Hawaiians, Pacific Islanders received worse care than whites, according to about 40% of all quality measures of healthcare in the United States, 40%. Hispanics and Asian Americans followed suit with 35% and 28% respectively. So disparities for poor and uninsured populations are persistent and a major concern in the areas of quality of overall health. One of the most interesting components that I saw come out of this was the measure with the largest income disparity is people without a usual source of care who indicate a financial or insurance reason for not having a source of care. So those who are falling through what we call our safety net, they're not able to have conventional care, and they may be extremely rural or don't have the opportunity for transportation to visit a safety net hospital. So these are the ones falling through the cracks. And what that identifies is that, we don't, not only do populations who are considered vulnerable experience disproportionality of higher or worse healthcare outcomes, there's also an imbalance in the distribution and access to these necessary resources. So in closing the loop, my background is also in health informatics, so I'm very data-driven. And if we're not able, so federally qualified health centers are very good at this. We need to learn this in conventional healthcare. We need to capture social determinant of health data consistently. And that way, we're not putting data in this population of information where we're missing subsets of the populations who need it the most. So we need to have standardized protocols for collecting. That means standardized terminology for collecting health disparities. So all of the capturing information for all the enabling services and social determinants of health. This way we can risk adjust and fundamentally change how we reimburse health services. So it can be proactive, so we can utilize enabling services versus just paying for a unit of care or volume of care. And in able to do this, we need to partner with our public health, and that's what our federally qualified health centers are doing very effectively as well. And then in doing this, we can share information with each other, and we can utilize our enabling services to provide a more holistic care for a patient.
Okay, thank you, Dr. Palki. You said a lot of very intriguing things in your talk that we would like to piggyback on later on when we have our Q&A. And for anyone listening, if you have any questions for Dr. Palki, please make sure you put them in the chat area and we will get to them during the Q&A section. All right, our next panelist is Tiffany Donaldson. Tiffany is the president and CEO of Connecticut Health Foundation, overseeing the independent health philanthropies work in grant making, policy advancement, strategic communication, and leadership development. She brings to the role a deep knowledge of healthcare systems and policies, extensive experience in grant making, and a commitment to equality. Tiffany previously served as the Foundation's Vice President of Programs, and before joining the Foundation in 2014, Tiffany held several leadership roles at the Aetna, including as the Deputy Chief of Staff for Aetna's National Business Office and as a Director of Corporate Strategy. She is a graduate of Georgetown University and received her MPH in Health Policies and Management at Emory University's Rolling Schools of Public Health. Tiffany, please share with us what insights on healthcare inequities and trends for solutions as it relates to your work. Tiffany?
Tracy, thank you so much for your introduction. And I also really would like to thank the Charter Oak State College Foundation in particular, Ann Elwell and Carol Hall for inviting me to this Shea lecture. I really have to thank Dr. Palke because she set me up beautifully. So thank you so much. And in talking about what we deem the social determinants of health and what really drives healthcare and drives the health of an individual. As Tracy said in her introduction, I'm from the Connecticut Health Foundation, and we are focused on health equity specifically for people of color here in Connecticut. Our goal is to assure that the policies and practices that really impact the residents of Connecticut, and particularly people of Connecticut, the policies that impact them, really help them become healthier. And why do we need this? So most people, when they think about Connecticut, they think of Connecticut as being one of the healthiest states in America, and we are. Connecticut is often deemed one of the top 5 healthy states in the US. However, if you dig a little bit deeper, while we are overall a healthy state, Connecticut is ranked normally, and even in 2019, ranked at the bottom 40 related to health disparities. And this ranking in particular comes from the America's Health Ranking, and they base this information around the disparities that we see in education, income, housing, and how that impacts one's health. Again, speaking to Dr. Palke's overview of the social determinants of health. So why is Connecticut so healthy on one side, and on another side, it is not healthy? Again, breaking the information down, we as a foundation look very closely at all of the elements that impact health for people of color. So speaking specifically, there are lots of studies around our state around this. And in particular, Data Haven is an organization that looks very closely at what impacts one's health. And they provide data every year on that. And as Dr. Palke talked about transportation issues, the most recent study from Data Haven showed that only 65% of Black and Hispanics felt like they had access to a car very often or often. That means that 35% of the population don't even have access to transportation to make it to a doctor here in Connecticut, versus 87% of whites here in Connecticut. Again, speaking to the disparities. When we look at, I know we're going to talk about access to food. If you look at access to food, the data also shows that 23% of African Americans and 28% of Hispanics here in Connecticut said that they did not have enough money in the past 12 months to purchase the food that they needed, versus only 10% of whites here in Connecticut. Again, speaking to what impacts one's health, it's the ability to access food. It's the ability to drive and make it to your doctor. It's the ability to be in a safe neighborhood and to walk and to get the exercise that you need. And even related to safe neighborhoods, 40% of African Americans and 43% of Hispanics felt like their neighborhoods were not safe enough for them to walk around, versus 26% of whites here in Connecticut. So we are seeing disparities on so many levels related to assuring that people have the access to live their healthiest lives. And how this is playing out is disparities across the board, even before COVID-19. So even the access pieces that I just spoke about, that was before COVID-19. And we know that this is going to be exacerbated because of this pandemic. But even before COVID-19, if we look across most chronic conditions, people of color fare far worse here in Connecticut than their white counterparts. Even as we think about children and children that we love so much, who should be able to live their healthiest lives, if we look at asthma in particular, Black children and teens are 5 times more likely, and Hispanic children are 4.5 times more likely to have to go to the emergency room for asthma. Asthma, a very controllable condition. They have to go to the emergency room for that because they don't have the ability to control their asthma because of so many of their environmental factors. And even related to asthma, African American children are 4.5 times more likely, and Hispanic children 3 times more likely to be hospitalized for asthma. And this shouldn't be the case here in Connecticut. It also just impacts the way and our ability to live. We work very closely with a lot of partners, as you can imagine, and there are a lot who are studying all of the health disparities around this state. And there are some studies that indicate even just the life expectancy and what the difference is between those who are living in different neighborhoods. For example, I recently just moved from West Hartford, Connecticut, and the life expectancy in West Hartford is 84.6 years. Now, if you just go down the road less than 5 miles to Northeast Hartford, or as we consider the north end of Hartford, the life expectancy is 68.9 years. That means going less than 5 miles, you are expected to live 15 years less just by going down the road. And it all speaks to the access to education, the access to the right income, the access to the appropriate housing, to the appropriate transportation. All of those things that keep us healthy and well is what that really speaks to. And so as a foundation, we constantly have to ask ourselves, and we ask our partners, and I will ask you as well, what can we do in order to assure that the next generation does not face the same health inequities that we see today? And I call them health inequities because inequity or equity speaks to directly the systems that impact health. Again, as I mentioned in my opening remarks, we as an organization are focused on the policies and practices. So what are the policies that really can impact an individual's life, and how can we change that so that we are healthier? We are in an election year, so one of the most basic solutions is to vote. All politics is local. And at the end of the day, as we think about some of the housing and some of the educational policies, those are all happening at a local level. So I really encourage all of you, I know we've seen it all around, but to vote for those who you believe are standing for what you think will improve the way that people are living in your neighborhood, and again, right down the street. The other component of it, as we've talked about around the social determinants of health, is that we have to continue to figure out ways to better link the healthcare system with all of the social needs that one individual needs. So we have to think about how we can better do what we in the healthcare system in the field call better community clinical integration. How do we connect what the community needs to the clinical services? As Dr. Palke alluded to, very little of what impacts one's health happens in the healthcare system. Some studies show as little as 70% of what impacts one's health, or as much as 70% of what impacts one's health, happens outside of the healthcare system. So as little as 10 to 15% is what happens when you walk through a system's door. So how do we better link people to the services that they need outside of the hospital door? Some of the ways that we can do that is focusing on those who can help make that linkage. In particular, our organization is really focused on community health workers. Community health workers are individuals who are from the community and of the community. That means that they speak the language of those who they are helping, literally, figuratively, literally, culturally, and educationally. They are speaking the language of those who they are working with. And they often are conduits between the healthcare system and the community, and are able to connect people to the needed services that they have to have in order to keep them healthy. So we are really focused on how can we assure that community health workers are an integral part of the healthcare system. So that's one component of it. Dr. Palki also spoke about data. Data is critically important. You cannot improve what you don't measure. We all know that. We know that in our own lives. You cannot know how much weight you need to lose until you step on the scale. So related to healthcare, we really need to start collecting data by race, ethnicity, and language. So we need to understand across our state, and even within health systems, how different groups of people are doing and how the healthcare system is serving them or not serving them. And so we need to continue to think about how we can effectively collect that data. And I am proud that our state is continuously working on this. We work closely with the Office of Health Strategy, who is thinking about and building systems that can collect data across the state, and in particular, focus on race, ethnicity, and language data. So we need to continue to do that from a state and a healthcare systems level. The other piece of this is that we need to make sure that we keep people covered and connected to care. And so, I appreciate Dr. Palki talking about federally qualified health centers, and they are a huge partner of ours as the foundation. Federally qualified health centers will take an individual in regardless of their ability to pay. And as she also noted, they often connect individuals to the needed social services in order to keep them healthy. In addition to that, school-based health centers, we often think of our school nurses as those who we just put the Band-Aid on, but often in some schools, school nurses are key to keeping some people healthy. They are the ones that provide the right asthma treatment. They are the ones that understand a child day in and day out. So we need to continue to support. In addition to that, we need to make sure that people have the healthcare coverage that they need, that they even have the ability to enter the healthcare system. And so a lot of advocacy needs to continue to occur around assuring that people have coverage. This is a very big conversation, and it is ruminating and it's boiling over even to this day as we talk about coverage, as we think about the Affordable Care Act, and as we also think about Medicaid expansion and Medicaid coverage. So I continue to reiterate to just follow what is happening, listen to what is happening, and understand where you can provide any insight into the issues and where you can start to think about solutions for how we can solve some of these issues that are facing us around coverage, around data, around connection to care, and around access overall for people who are doing far less better than others. So really thinking about this issue. The last thing I want to hone in on, and I think that if you listen to Fred McKinney's talk, he talks about this a lot. It's just the fact that, and especially during this climate, and even the reason why you all are having this talk, it's just thinking about the racial inequities that are happening across our country, but also that really impact one's health. So even as individuals and as healthcare systems and overall, we really need to think about how racism impacts the way we treat each other and the way people are treated in the healthcare system. And in particular, we recognize that there are clear areas where we know that race is really what matters and what impacts one's health. For example, we know that in child and maternal health, race is the primary factor for why women are not doing as well. We know that in the United States, a Black woman with a college degree is still 1.6 times more likely to die from pregnancy-related causes than a white woman without a high school diploma. So at the end of the day, even though social determinants of health are so important for us to look at, we also need to consider how race, how racism, and how systematic racism impacts the way that we are treated in the healthcare system. And I think we all can play a part, and we all have a role in really understanding those dynamics and understanding what we individually can do about it. At the end of the day, there are a lot of issues that we are facing every day. We saw COVID-19. We saw how COVID-19 impacted communities of color here in Connecticut. Even to this day, Black individuals are 2.5 times more likely than whites to get COVID-19 if you look at the rate, and Hispanics are 3 times more likely. But even what's harder to understand and know is that African Americans are almost twice as likely, over twice as likely to die from COVID-19 than their white counterparts here in the state of Connecticut. And so what I would like to deplore all of us is to think about how can we equal the system so that even as we continue to face COVID-19, even as we look at the health inequities across our state, we can all come together to develop some solutions and to work together so the next generation has the opportunity to live their healthiest life. Again, thank you so much for inviting me.
Thank you, Tiffany. You gave us a lot of statistics, and some of those statistics I know were shocking to me. So I can only imagine what some of our audience members are thinking right now, because I was very surprised by some of the statistics that you gave. All right, so we are shifting gears a little bit, and we're going from health into food insecurities. You've probably seen our next speaker all over the news stations during this pandemic as he works to provide food services to so many. Jason Jabowoski is the president and chief executive officer of FoodShare. He joined FoodShare with over 15 years of experience in public health, public affairs, nonprofit leadership, and community relations. Prior to joining FoodShare, Jason was the vice president of external relations at the Hospital of Special Care, and was responsible for all government relations and public community development at the hospital, its foundations, and also subsidiary programs. Also, he previously worked as director of corporate and community development at the Charter Oak State College. He was elected twice to the New Britain City Council and served 2 terms as city treasurer. Since 2006, he has taught public science at the Central Connecticut State University. A New Britain native, Jason holds both a bachelor's degree in public science and a master's of public affairs from the University of Connecticut. Jason, if you can think back before the pandemic and give us a brief discussion on food insecurities and then what it looks like now, 8 months into the pandemic. Jason?
Yeah, absolutely. Thank you very much, Tracy, for that introduction, and it's a pleasure to be on this panel with Tiffany and with Brooke. I really appreciate it. Coming to you live from Food Share this afternoon. We had a busy, another busy day here today, providing food to folks here in Hartford and Talon County. Very happy to do this as well because of my affiliation with the two organizations that are putting it on. First, I'm a proud board member of the West Hartford Chamber of Commerce, also the town where I live, and I'm very happy to wear that on my sleeve, and also my longstanding affiliation with Charter Oak State College. I can see the thing reflecting in my glasses, so I'll take them off. It's okay. But also my longstanding relationship with Charter Oak State College. My first job out of grad school was with Charter Oak. I spent 8 years there, 8 wonderful years working at Charter Oak State College. I have taught there since 2008. I still teach American government at Charter Oak, and I have also been on the Charter Oak Foundation board for the last several years. So these are two organizations that are near and dear to my heart, and obviously talking about a topic today that's very near and dear to my heart. I'm a Connecticut guy. I've spent my entire life here in Connecticut. I was born and raised in New Britain. And went to the University of Connecticut and now live in West Hartford. And one of the things that being a Connecticut guy and a Connecticut person I can attest to firsthand is just this great economic divide here in the state of Connecticut. And it's interesting because you don't see such disparities in other states. Connecticut, by most measures, is the richest state in the country. That's an amazing statement to say in the year 2020, and there are many states that have a tremendous amount of wealth, but by most measures, Connecticut is the richest state in the country. Connecticut also has some of the poorest zip codes in the entire United States of America. Which is stunning when you think about it, and you think about that disparity. Yes, we have Fairfield County, and within Fairfield County, you have Greenwich, which is one of the richest towns in all of America. You also have Bridgeport, just a few miles away, which is one of the poorest cities in all of America. I say to my team all the time, we service Hartford. There are mansions in the city of Hartford, legit mansions. There are a tremendous amount of wealth and a tremendous amount of wealth that has been there for many, many years. There is also a tremendous amount of poverty. Again, some of the poorest neighborhoods in the entire state of Connecticut, all within the same municipality. I mean, one of the things that we have, one of the issues that we have here in Connecticut, and we all kind of like laugh about it, is this idea of 169 towns. We have 169 towns in this little tiny state. And every one of them has their own character, and we like their individuality, and that's lovely and everything. But it's not really a practical way to run government and to provide services to individuals. And what it actually does is, by having so many little hamlets and little municipalities, you end up highlighting those disparities that exist within various different communities. So yes, we have that charm here in Connecticut of the individual towns, but it also helps contribute to this great divide that we have here in Connecticut. Among the towns in our service area, and we service Hartford and Talon County, there are urban areas, there's suburban areas, and there's rural areas. And when we talk about food insecurity, we talk about food insecurity in each of those 3 different areas. At least once a week, somebody will say, "Oh, you guys service, Hartford and Talon County. That's nice. You must give all of your food to, you must give a lot of food to Hartford and to New Britain." Yes, Hartford is the number 1 municipality on our list, and New Britain is number 2. But we also have a tremendous amount of food that we give out in towns like Avon, Simsbury, Farmington, West Hartford, Glastonbury, towns that you would think are affluent, even though they're suburbs. You look at the mean or the median household income in a lot of those towns, and they tend to be pretty impressive. But that doesn't mean that everybody, that is the mean or the median. That's what's in the middle. That's not what's at either end of the spectrum. The other thing that we deal with is a tremendous amount of, so there's definitely food insecurity in urban areas. There's definitely food insecurity in suburban areas. And then you look at the rural areas that we have. Small towns like Willington and Union and Ellington within our service, our service area. They deal with food insecurity as well. In some cases, it's because there's not as much physical access to to grocery stores or to food outlets. In other cases, they have very aging populations, and senior citizens tend to be among the greatest victims of food insecurity. So the lesson I've learned in my 3+ years here at FoodShare, and actually I would say my 40+ years here in Connecticut in general, is that hunger does not care where you live. Hunger doesn't care what your zip code is. Hunger doesn't care what the median income of your town is. It does not discriminate in that way. But as a result, you've got pockets of poverty in all 169 towns here in Connecticut, even in Greenwich, which is held up as the national standard of rich municipalities. The conditions that I'm discussing, and I can give you some statistics. In what we would call normal times, there's about 118,000 people in Hartford and Talon County who are food insecure. It ends up being about 1 in every 9 people, about 1 in every 7 children. We think that's completely unacceptable. Here at FoodShare, we distribute about 11.5 million meals a year during what we call normal times. So these differences, these economic differences, certainly exist during what we would call normal times. However, I don't think I can overemphasize this enough. These are not normal times. There is nothing normal about the world that we are living in right now. All of those norms went out the window in the middle of March when this unfortunate global pandemic has really changed every bit of our lives. The inequalities that exist during normal times have only been exacerbated during times of COVID. And I'm glad that Tiffany had mentioned that as well, because it's true. You see statistics on the news, but sometimes you don't really grasp the reality of it. One of the things that I've observed in terms of the type of work that we do is that exacerbation, the fact that there is this greater chasm between the haves and have-nots, it's actually been masked by the sheer number of people who have needed to use our types of services and different social services during this particular time. You look at, what's one of the defining images of COVID here in Connecticut is the front page, the front page picture taken with a drone of Rentschler Field in those very early days of COVID, with the lines of thousands of cars wrapped around the stadium over and over again. That image in the public mind, first of all, it certainly is, well, certainly accurate. I was there. I saw it. I can't say I took the picture because I don't know how to use those little drone things there. But it is definitely accurate. The second piece of it, though, is that those people that are there, it tends to mask. You're looking at cars. You're looking at the tops of cars. You're not necessarily looking at the individuals who are in those cars. And those of us who are on the ground and those of us who are out there at Rentschler Field and who are at our local pantries and at our local mobile sites are able to see the actual individuals getting food. And I could tell you the divide between the haves and have-nots has increased significantly during COVID. Just some statistics in terms of what we've done at that Rentschler Field distribution in particular. Since COVID has started, we have served more than 200,000 households. More than 200,000 cars have driven through Rentschler Field and and gotten food. We've also distributed more than 5 million meals, which is more than 6.2 million pounds of food. That's just at Rentschler Field, at that emergency food distribution. That's not a permanent distribution. We're moving down to 2 days a week in November. It's not going to be able to stay open forever. It's very expensive distribution, but it was necessary in terms of how we had to distribute food, given the dynamics of this particular pandemic, where you can't touch things and you can't interact with people in close proximity. It's a drive. For those of you that don't know, it's a drive-through distribution, which only works in a situation like this, where people open their trunks and we put the food into their cars. So we've served more than 200,000 families there. One of the struggles, though, is always, like I said, last year we did about 14 million meals. A third of it was fresh produce. We've been trying to transition to more nutritious food. One of the things that you notice, again, it doesn't surprise any of us as consumers, but it is definitely antithetical to how things should be, but is this idea that nutritious food is significantly more expensive than cheap food. You take $1 and you walk into a grocery store, you can walk out of there with, I think, something like a six-pack of Twinkies. You can't even walk out of there with a loaf of bread for $1, though. You can't even walk out of there with more than 1, maybe 2 apples. It's a very difficult proposition. So one of the things that food banks across the country have been doing is really trying to find ways to increase increase produce. One of the other things that we've seen over these last several months is the number of families that have applied to use SNAP. And SNAP is what, when I was a kid, they used to call food stamps. It's the Supplemental Nutrition Assistance Program. It's a federal program administered by the state of Connecticut. An interesting stat, and I was blown away by this when they had told me this. In the first 3 months of COVID, March, April, and May, here at FoodShare, we enrolled as many families in SNAP as we did in the entire previous 12-month period. Between that and the number of cars we were doing a day at Rentschler Field, that was shocking. I am not an economist. I'm a political scientist by trade, but I can tell you that you don't need to be an economist to realize there is a major economic fallout from this particular pandemic, and it is having a disparate effect on different communities here in Connecticut and across the country, and I'm sure across the world. I often say to my staff and to folks that we're talking to about food insecurity here in this area, the increase in demand on our services has nothing to do with the biological virus in and of itself. The virus, what we're dealing with is the economic fallout of that virus. I've said this on TV a couple of times. The virus could be solved tomorrow, and we are still looking at anywhere from a 12 to 18-month lag on the economy. People are out of jobs. And when you talk to people, and we've actually had some of our survey researchers out there at Rentschler doing surveying cars. We've also had people have individual qualitative conversations with people. The first time we surveyed cars back in May, 75% of households that were coming to Rentschler Field had never used one of our services before. That number blew me. There's not much that shocks me these days. That number absolutely shocked me. But what it meant was that there were people that were gainfully employed, 5-6-figure salaries. They would tell you this. Sometimes, some people didn't like to talk. Some people definitely like to talk, but they'll tell you 5-6-figure salaries. I had a job. It was a great job. It's providing for my family. And just like this, a rug was pulled out from under them. And now they found themselves going through their savings, applying for unemployment, all of these different things, and realizing that, hey, what am I going to do? Am I going to pay for my rent? Am I going to pay for heat or electricity? Am I going to pay for medication? Or am I going to pay for food? Food's always the thing that goes by the wayside. And it's a very difficult reality. We updated those numbers a month ago, back in September. Still, at this stage of the game, 15% of the cars coming through Rensselaer Field had said they had never used our services before. And we're like, how is that possible? Well, we had savings, but we went through it. Well, my employer had payroll protection program, but then that ran out. Well, I had the $600 unemployment bonus, but that ran out. This is a real problem, and this is reality here in the United States, and certainly in the state of Connecticut. One of the things that I know I was asked to do was talk about solutions. And I think a lot of the solutions that I have are very much in line with what Tiffany and Brooke had said before me. But first of all, and again, as somebody who teaches political science at Charter Oak State College, I would not be doing my job if I didn't say the first solution is always to vote. There is an election, certainly an election next, in case you haven't heard, there is an election going on next week. But don't just vote every 4 years in a presidential election. Vote for local office. Vote every 2 years for state officers. There is nothing you can do more important than vote, because I will tell you, we see this every day with our discourse down in Washington. The people that win these elections, I always tell my class, somebody's going to win the election one way or the other. You might as well have a role in terms of deciding who it's going to be. So to me, that is the easiest thing that everybody can do, is you can vote. And by the way, every public official has a record one way or the other on a lot of these issues that we're going to talk about. Second solution, increase SNAP benefits. And this is twofold. One is in terms of the dollar amount. When I first started here, I took the SNAP challenge. Sometimes you read about people doing that, in which I lived for a week on what a SNAP allocation would. I ate for a week on what a SNAP allocation was, and at the time it was $35.50. I ate for an entire week on $35.50. It's not easy, and it's certainly not fun. Somebody had said to me, "Oh, that's great. You're going to lose a lot of weight and everything." And laughing at, no, because all you're buying is junk, things that are high in fat and things that are easily affordable. People talk about SNAP benefits and talk about how there's people who are opposed to SNAP benefits and opposed to programs like that, thinking that they're too generous. I'll tell you, we need to increase the amount of funding that we give to SNAP. At the same time, we need to expand the threshold by which people qualify for SNAP funding. SNAP is the first line of defense against hunger. For every meal that the food bank system in America provides, SNAP provides 9. That is incredible. And one of the things that you hear when they talk about cutting SNAP benefits, and actually this is something that the U.S. Secretary of Commerce actually said within the last 12 months. Secretary Ross had said, well, if people can't get access to SNAP, then they can just go to their local food banks. I can tell you, and I said this at the time, and I'll say it again, neither Food Share nor any other food bank in America has the food to be able to has enough food to be able to replace what would be lost by the SNAP program. SNAP is the first line of defense against hunger. It gives people dignity. It gives people choice. They are able to shop in the grocery store just like anybody else, and they use their card. Even the cashier has no idea where the card is coming from, and that's one of the reasons that we as a food bank group are very supportive of that. So the other thing, school-based meal access. Support school-based meal access and encourage your elected officials to increase school-based meal access. One of the things that happened, the first question I got during COVID was, well, what are these students going to do? Many students, again, even in a very rich state like Connecticut here, are in positions in which they are getting 1, sometimes 2, sometimes even 3 meals a day through their public schools. When their public schools go away, or when they have to go home and do distance learning, that is a major, major problem. We saw our numbers spike immediately at our local pantries and our local mobile food share trucks. So that is a major, that's a major issue. During the summer, it's a problem. Yes, the federal government has a summer meals program, and our folks at the state of Connecticut Department of Education do a wonderful job trying to promote it. But the federal government needs to increase that program. The hardest time of the year for food banks is the summer months, because kids are out of school, and now they need more avenues by which to get food. The last thing, my last solution is, again, support economic policies that help deliver people out of poverty. We cannot look at food insecurity in a silo. We cannot look at food security as in an isolated manner. The old way of doing things in this country and this world was, if you were a food bank, if someone's hungry, you give them a banana and they're happy. Nowadays, that's not good enough. We need to partner with other organizations. We need to partner with government in order to figure out why individuals are in that cycle of poverty and how do we break that cycle of poverty. We don't want our services to be a way of life for anybody. We want to be able to use our services to connect them with other organizations that can help deliver them and their families out of poverty. Because at the end of the day, yes, we do distribute food. That is our mission. But I see us as an anti-poverty organization. And despite the wonderfulness of Connecticut, a place that I love very much, and despite the great amount of wealth and dignity here in the state of Connecticut, there is still a tremendous amount of poverty here in Connecticut, and it's only been exacerbated over the last several months with the COVID pandemic. So with that, I will again thank you guys for having me on the panel, and look forward to some questions and more discussion.
Thank you, Jason. That was some very insightful information and a lot of actionable steps to solutions for when it comes to food inequities in our community. I want to go back to Dr. Palki and ask you to give us 3 solutions that you think can bridge the gap of health inequities in our communities, in the minority community, in your community, in anyone's community. What are 3 solutions that you think will help to solve this issue?
I think I would start with being informed. Information is so critical. When we think about, and I just have to say, Jason and Tiffany, I'm just blown away, and I think that we're going to be able to see some commonality between what we talked about weaved throughout all of the issues that we have talked about, and policy has come up several times, and I think it's so important. Tiffany, you brought up outcomes, and when you talk about policy, and if you don't have the driving policy to develop and support these programs in a consistent way, you're not able to compare apples to apples. So if we have policy driving our public health like we do our conventional health, it's going to make a huge difference. If you think about, I just saw this the other day, the WHO, World Health Organization, actually rates the United States 33rd in terms of our public health initiatives. Really low. And if we think about how conventional health is driven, you have the same diagnosis per protocol. The protocols might be a little bit different, but you'll have the same diagnosis no matter where you go. If we don't have a way to capture the social determinants of health or the inequities the same way, we're not going to be able to compare apples to apples. So that information has to be collected the same, it has to be assessed, and it has to be acted upon. So when we think about medical protocols, we need to have the same type of protocol to capture social determinants of health. And so there are some out there. One of the most common ones that is being utilized right now is called Prepare. And what it allows you to do is it allows you to risk assess. So if you risk strategize any patient coming in and you look at them holistically, you're able to see, okay, so in this quartile, here's their medical. In this quartile, here is the social determinants. And you get points based on each one, and it gives you the risk stratification. So an example of a risk stratification in social determinants of health is called CARET healthcare risk stratification. And so just like medical care, it will give you some preventative measures, and it will give you how much something would cost. So if it captures points on food inequity, if it captures inability to pay for prescriptions, if it captures housing, then you have a higher weighted quartile in social determinants of health in comparison to medical. And typically what you're going to see is the medical is something that is a chronic condition. So they directly impact each other. So if you're able to capture that, risk stratify it, and we reimburse healthcare differently, we're gonna be able to level out that playing field and information exchange. So we have become better about sharing information with our behavioral and mental health profession. So it's not perfect, but we're much better. We know that there's a correlation between physical health and mental health, okay? We also know that there's a direct correlation between physical health and dental health, but they don't talk to each other. You know, we know that there are all of these correlations, but if we don't have a way for that information to be distributed, we're always going to have these gaps. So we have to have a way to driven by policy on how to capture this information so we can capture it and then reimburse it. So if there's an organization that provides a higher level of a population that has higher level social determinant of health weighted outcomes, they would be reimbursed differently than someplace that does not. So we have to fundamentally change how we capture and reimburse care in this country. And if we're able to utilize health information exchange, we can share that information with all of the public health and enabling services that are trying to do this, to all do the underlying job of improving somebody's overall health. So we have to be able to communicate. I know I said that was one, but there was many components of one. The other thing that relates to health information exchange is technology. If our health system is going to rely on technology, which it does, they're mandated to be on electronic health records. If they're going to be mandated, we need to get broadband out to everyone. If particularly now when we've talked about the pandemic and exacerbating all of these issues, we've seen an increase in telehealth, and we've seen an increase in patient portals. But if somebody doesn't have the broadband to be able to do telehealth, you're going to have a phone call which is reimbursed. That's telemedicine. It's going to be reimbursed differently than telehealth, and the healthcare organization is not going to want to do it. So if we're going to do that, we got to make sure everybody has broadband. We also have to make sure that if we're going to set these up, that we set up the processes, whether it's patient navigators, whoever it is, someone to assist patients setting this up. Have you ever tried to set up your own patient portal? It's not easy. And if you have a minor child, you have to get a PIN. I mean, there's all these steps you have to do. And are you thinking about that when you're setting this up? Do you require your patients to log in through the patient portal to use telehealth? What kind of roadblock does that set up for your patients? So what kind of technology, how we use the technology, using the technology to share the information And then once we do that, we need to look at is enabling services, and Jason, I think you brought this up, are those, you know, siloed? They're siloed now. They cannot be siloed any longer. Can we have our medical transportation vehicles assist with food delivery? Do they only have to go to these houses to do one thing? You know, it can be really isolating, especially during these times. And, you know, when we're doing telehealth, I know I have a colleague who works for a federally qualified health center here in Minnesota, and what they have are what they call swab squads. Because when you look at testing centers and where they're set up, and they're not easily accessible for everyone, that's for sure. And so they were having these swab squads go out for testing, but instead of just doing testing, they were also doing other intakes to see what people's needs are. Okay, and so what we really need to do, ideally, is establish a healthcare home. So it's not these siloed components, and this all information needs to be looped back to this holistic version health of a patient and not just the clinical care. And then we need to teach that in education, higher education. If we're teaching healthcare, we can't teach them these siloed processes. We can't teach them to each live in their own individual components with social services here and nursing here and medical way over here. We really need to think about going fundamentally back to the foundation of how we're teaching education in healthcare, how we're reimbursing it, and how we're transmitting information with healthcare. Hopefully that makes sense.
Yes, it does. Thank you for that information. But I do have a follow-up question. With all this technology, and I know other people are probably thinking this, will it affect our HIPAA regulations? Like, you know, is that too much information out there for just almost anyone to access? How is that going to affect people's sense of privacy?
Absolutely, and I'll open this up to anyone else who wants to jump into. But if for the longest time we haven't incorporated EMS information directly into an EMR and EHR, well, they have figured out how to do that. They have figured out how to communicate with the local behavioral health centers, and those are all grant funded. They're not always part of big health systems. They have learned how to transition that information between each other. And a lot of times it has to do with health information exchange organizations, or HIEOs. And so it's not direct sharing, but it's direct access. So for example, Connecticut is in the process of starting their first health information exchange organization. Minnesota has one, and we're also part of a regional one. So what you do is you send it up to the organizational level of the health information exchange organization, and then let's say the behavioral health organization also taps into that with appropriate information, and it's provided to them. So there's still checks and balances, and it's not going to be delivered directly, but it's through these organizations that have been implemented from a national directive, so that information can be shared. You know, think of our snowbirds. You know, they go down. I think of this all the time because our population drops during the wintertime. They all go south, and they still need to have access to their health information. Their healthcare organization there to see someone in the South doesn't call directly to the healthcare organization in Minnesota. They go to the health information exchange to get that information to be able to better assist that patient. And so there's definitely ways to do it. We just need to be able to expand that to the other services.
Thank you, Dr. Palki, for clarifying that. Okay, so Tiffany, I have a question for you. So you gave us a lot of data about things that are currently going on in Connecticut that was quite surprising to me, and I know it's quite surprising to a lot of our audience and members as well. one of the things that you talked about, which piggybacks on what Jason was talking about as well, is that 23% of African Americans and 28% of Hispanics suffer from food insufficiency. And then you also talked about the fact that access to transportation is one of the reasons why they can't get the medical care that's necessary. And then the third thing you talked about, which is near and dear to myself, because I have asthma, my daughter has asthma, and we have hardly ever had to go to the hospital because of an asthma attack, is the fact that you say so many African American children end up in the hospital due to asthma attacks. And I just kind of wanted you to elaborate a little bit more on those points and then give us some solutions as to how we as a community can help to bridge those gaps.
Yes, thank you. And I will note the asthma, I always bring that statistic as well because it's near and dear to my heart because my daughter also has asthma. And similar to you, we've never had to go to the emergency room. We've never had to go to the hospital in order to maintain her asthma, but we were able to do it through just working with our pediatrician and protocol at home. But that speaks to the fact that I have the ability and access to continuously be connected to the care that I and my child needs. And often people do not have that access. The other piece around this is that, you know, if you think about Maslow's hierarchy of need, people have to ask themselves, and Jason spoke to this as well, they're constantly individuals making tough choices every single moment of the day. Do I take time out of work to go to the doctor when I may effectively potentially lose my hourly wage job? Do I pay for that medical bill that I know will come if I go to the doctor? Or do I focus on paying for the food I need or for the rent or for my kids? And so again, we have people who have to make really tough choices around their care every single day. And that is what often leads to that. At the end of the day, I am one who completely believes in moving upstream. And we've got to think about how are we setting people up for success from the beginning. So what are we doing to assure that we are reinvesting in communities that have been historically disinvested over time so that we can make sure that they have the access to what they need, the access to the education that will set them up for success, access to affordable and healthy housing that often impacts asthma and other conditions, access to food, you know, being able, I have done this several times, people don't realize that Hartford itself, and Jason, I'm sure you can speak to this, is a huge food desert. Even if you had the dollars to buy groceries, the local grocery, this local Stop and Shop is miles away, and it's challenging even to get there. So thinking about how do we reinvest in community so that they can start from a good place so that they can end at a better place. And I think that that's really important for us to think about. So when you ask what are solutions, again, and Jason and I both spoke to this, understand the problem so you can know how to solve it. So we need to understand, again, how people even just down the road from us are experiencing life and thinking about what are some of the policies. We all keep saying this, and I appreciate that. It's because policy impacts systems. We are basically living in the system that we designed and created through our policies. We are living it because of the way that, again, we looked at our federal and our state and our local budgets and what we decided to invest in and who we decided to invest in. We have created it related to how we have looked at all of our educational and employment policies. So we need to take a step back and undo some of the work that we did with the policies that we have today. So I really encourage everyone, again, and Jason and I both said this, vote for those who you think are going to change and rethink some of the work that we have already done in Connecticut and rethink how we can do it better to really impact and help all Connecticut residents. The other piece around it is that we need to make sure, again, that there are people in community and the healthcare system who are thinking about this daily, who are thinking about how they can make sure that a person who has a language barrier has access to the services that they need and a translator, who are thinking about how that individual with diabetes is able to, even if they have a house where they can put their insulin in a refrigerator. And that is again around community clinical integration. So thinking about how can we better link community, the needs of community with the healthcare system. And the last thing that I would continue to say and to focus on is that we all really can play a huge role in just giving and thinking about how we can support those in local communities who need services. I would, we're a foundation, we're able to provide big dollars, but it is amazing how much little dollars that are donated will go. And I often think about, even thinking about Jason's organization and how far we'll go to support organizations like that and them and those who are really reaching the community and are really reaching those who are in need. There are so many community-based organizations that are also in dire straits because of COVID-19, because of challenges with fundraising and things on that order. So we all really need to think about how can we better support those who are on the ground, who are making sure that community members are healthier. And we all can play a role in doing that.
All right, thank you, Tiffany, for those solutions. We're gonna go back to Jason. I know that you basically gave your solutions to the issue when it comes to food insecurity. If there's anything else that you wanna add to it, you can do that now. I also know that in the next, maybe about 2 to 3 weeks, you're gonna have a food drive for Thanksgiving. If you wanna talk about that, let's talk about that as well. Jason?
Yeah, sure. I'm happy to do that. And we're definitely, here in food banking, it's an interesting proposition because our two busiest months are the last 2 months of the calendar year. People are constantly thinking about food insecurity in November and December, mostly due to the holidays, Thanksgiving, the December holidays. People, nobody should go without a turkey at Thanksgiving. Yes, absolutely. There's no disagreement on that. The sometimes frustrating thing for those of us in food banking is, hey, there's another 11 months out there in which, the Thanksgiving turkey is important, but, helping people to maintain food insecurity throughout the year is important. That's why when we created, it started as turkey in a 10, and then it grew to turkey in a 20, and it's been turkey in a 30 the last couple of years. I have not increased it since I've gotten here, but we call it our Turkey in 30 campaign, and the premise is that you donate a turkey now for a family in need and $30 to help us do our work throughout the rest of the year. A $30 donation, or every dollar donated to Food Share is enough to provide 2.5 meals. That would be 75 meals that you would get out of a $30 donation. This year is going to be different. I just had a conversation with a reporter from the Hartford Courant. This year is obviously going to be very, very different. We are not able to go outside of grocery stores and outside of churches and places like we usually do with our big bin and our truck and collect turkeys. It's going to be a virtual Turkey in 30 drive. We are purchasing turkeys and asking basically individuals to donate a virtual turkey. You donate a virtual turkey for $16, we'll go out and we'll buy the turkey and we will deliver it to a family in need. We typically have about 15,000 turkeys these last couple of years that we've delivered here in central Connecticut at Thanksgiving time. This year we're expecting over 20,000. Those numbers are still coming in. So it will continue. It has to continue. We know that it's going to be very difficult. It's going to be different. I think that's what I said to the reporter the other day, is that, or earlier today, is that it's going to be different. And I know we're Connecticut. We like our traditions. We like, oh, I take my kid and we take our turkey and we put it in the bin. I get it. But this year is going to have to be a little different because the world has dictated change. I'm going to piggyback on some of the things that Tiffany and Brooke had said too, is regarding public policy. And again, I mean, I'm certainly taking advantage of the fact that we are, less than a week before a presidential election. But again, I wouldn't be doing my job as a political science professor and a public policy professor if I wasn't talking about the natural connection between politics and public policy. And people who see politics as a game or a horse race don't realize that there's a lot behind it. The individuals who win next week, and whether we're talking about the presidency or control of the U.S. Senate or House of Representatives or State House or State Senate, are going to be empowered to make these policy changes. We live in a democracy in which the types of things that we're talking about here are ultimately solved by ourselves through our elected representatives. So I cannot stress enough the immediate connection between those things. We talked about staying informed. That is so essential, especially in today's environment. One of the things I say to my class every semester is the best thing about American democracy is all you have to do is be 18 and breathing in order to vote. And the worst thing about American democracy is all you have to do is be 18 and breathing in order to vote. It is a double-edged sword. Just because, I teach political science, I'm a dork, I'm a nerd, I'm immersed in this stuff. I look at polls, I know stances on issues. My vote counts just as much as somebody who says, oh, I'm voting for this person because I think they're attractive, or I'm voting for them because, they play the saxophone well, or something like that. As an electorate and as citizens, I'll even take the politics out of it. As citizens, we have an obligation to learn more, to become more informed, and to take a more active role in shaping these policy decisions, because there is absolutely a direct correlation between those types of political decisions and the policies that trickle down to affect real people in real in real everyday life.
Okay, Jason, they're asking for the link for you to share the link so that they can donate turkeys, virtual turkeys.
It will be, it goes live November 1st. So we will definitely, the link is foodshare.org, but the virtual turkey drive doesn't go live until November 1st, but I appreciate people's eagerness and tenacity by which to donate those virtual turkeys. But we will definitely send it out once the link goes live.
Okay. I want to say a very special thank you to our panelist members today for all of the information that you gave us today to think about. It's food for thought, things that we probably didn't know, things that we didn't think about before, solutions that we can now talk with our family, our friends, our community as a whole in order to see how we can help to solve the problem. Dr. Brooke Palke, thank you for being here today. Tiffany Dawson, thank you for being here. And Jason Jabawowski, thank you. We're going to move towards closing remarks from Glenn Davis. Glenn is the first Vice President of Community Development and the CRA officer of Liberty Bank. He's responsible for managing and overseeing the bank's Community Reinvestment Act, which is the CRA compliance program, which incorporates working with appropriate business line managers to advance the bank's lending, investments, and services efforts in accordance to the CRA guidelines. He's also tasked with implementing the bank's statewide community development initiatives, example, financial education programs, affordable housing forums, first-time homebuyers education, etc. Glenn also plays a leadership role in providing oversight of the bank's fair lending performance and training. Glenn serves the community on a variety of boards and organizations. Notably, he is a board member of the Charter Oak State College Foundation and a steering committee member at the Partnership of Strong Communities. Glenn has a bachelor's degree from Fisk University and a master's in management from Cambridge College. Glenn Davis.
Thank you so much. It's certainly a pleasure to be here and to share in this experience. To our panelists, to Dr. Palkey and to Jason and to Tiffany, you have provided us with some insightful and very provocative information and a very insightful discussion. You know, it's really amazing, Dr. Palkey, just to really hear how each of you have come from very different perspectives, but those perspectives are very seamless. And so I applaud you on that. But the thing that I found was interesting is how you indicated, Dr. Palkey, that 75% of the challenges that happen in the medical field are really not really attributed to a medical condition, but they're really social determinants or social impacts. And so that's really an interesting dynamic that I guess what we're really trying to do with the Shea Lecture is really to provide some thought and some discussion around this topic to really help move these disparities. Again, I really want to thank Chris and his wonderful staff at the West Hartford Chamber of Commerce for all that you've really done to really make this forum happen and how you just continue to advance this process. Really looking for the Shea Lecture 3. Again, you know, I want to commend Ed Klinowski, president of Charter Oak State College, and to all the my wonderful colleagues on the Charter Oak State College Foundation board. Just thank you so much. And to our able and efficient staff person, Carol Hall, thank you so much for helping to convene this. Again, this is really the second of a three-part series. And I just hope that you've all really kind of not just enjoyed the discussion, but really has been thought-provoking. And that's really what we're trying to do, is to really stimulate the thinking process and really to motivate and galvanize individuals to action. I think Jason, Tiffany, you said it quite clearly, the real key is to vote. And it's amazing how we really come back to that just at a very local level, not just now, but also in the future. So thank you again to all for just participating. Thank you for our panelists. Again, I commend you for your insight. Thank you for giving us your time. And with that, I'll turn it back to you, Carol.
Thank you so much, Glenn. And I would like to say thank you to everybody also. And also just a few things that I wanted to point out. This phrase that is now going to be my new mantra: access to live their healthiest life. We heard Tiffany say that. We heard Dr. Pelkey say that access and coordination of care is important. And then we heard Jason say, break the cycle of poverty. You know, the Charter Oak State College Foundation works all the time to break the cycle of poverty through higher education, degree advancement. This Shea lecture series is not being done in vain. We want to keep this conversation moving forward and educate people on things we didn't know about. And as Glenn Davis this lecture, December 3rd, Shea Solutions. We're going to bring President Ed Klonowski of Charter Oak State College into the conversation. We're going to work as a team with all of our past panelists to come up with plans and steps to level the playing field. We want to have an actionable, achievable, solution-oriented white paper at the end of this discussion. And we really appreciate everyone's questions, everyone's comments in the chat. We appreciate that there is a secret superpower in giving to the communities. So find your superpower. And this season, if you are fortunate, please consider giving to those less fortunate than you. And without further ado, I'm going to say thank you and good night. Again, we are going to meet again on December 3rd. So watch the Charter Oak State College Foundation website and the West Hartford Chamber website for links to register. And everyone have a happy Thanksgiving. Thank you. Bye-bye.
Bye-bye.